Welcome to Medications for Opioid Use Disorder in Jails, Why Access is Imperative for the Justice of All Population. Today we have Dr. Mark Stavros and myself, Diana Snyder with FATA, to present this information for you and hope that it will be helpful. All right. We have no disclosures. And Dr. Stavros, do you want to take over?
Yeah, hey there. I'm Mark Stavros. I am board certified in emergency medicine as well as addiction medicine. And I've been in the panhandle of Florida for, 30 years now. So working in the ERs, but also seeing a large amount of patients struggling with addiction. And I actually lost a sister to addiction. And so taking that pain and turning it into passion, I really just found that we could do a better job taking care of patients that were struggling with addiction. And so, not only in the ER setting, but also in incarcerated settings, we were failing these patients. And as I started learning more about addiction, I started realizing, like, wow, we could totally do this differently. And these are opportunities for patients, right? Opportunities for people to get the help they need, life-saving help, not only in the ER, but even in the incarcerated setting. So we're going to really focus kind of in that incarcerated setting at this point. So let's talk about jails and opioid use disorder. In 2019, almost 15% of jailed individuals had opioid use disorder, which is actually 9 times higher the general rate of the population. So that's, obviously we see a large amount of patients, a high percentage of patients going through the jail system incarcerated that have struggled with opioid use disorder. So great, that's where they are. We have these patients, we need to do something about that. What we've traditionally done in the past is detox most of these patients. And we're like, okay, we're going to detox them. And now they've stopped using drugs. And when they are discharged out of the, incarceration and they go back into society, they probably learned because they were just punished going to jail. And now they are not addicted anymore because they've detoxed off everything. And we realized that was completely wrong. Upon reentry, these patients are 129 times more likely to die from an overdose. And let me put that in perspective. If I told you that's 2 times higher likelihood, 2 times higher, that's 100% increase. This is 129 29 times more likely to die from an overdose within the first 2 weeks. So that is profound. We're losing so many people to overdose afterwards. And basically it's because they lost their tolerance. And when they went back to people, places, and things again, and they had a relapse, they would typically use what they used before. And even if they used less than what they used before, it's still too much. It was a toxic overdose. Opioid use disorder is linked to higher recidivism and reincarceration rates. We'll talk a little bit about that as well. If we do not treat OUD and we let people back out in society, guess what? They're going to use again. We see them come back through the system again. They get reincarcerated if they don't die. 41% of the arrested individuals and 49% of those in state prisons have substance use disorder of some type. Next slide. So let's talk about how we've approached this before in the past. If you look up opioid use disorder, almost all addictions, we look in a behavioral manual. It's called the DSM-5, right? So if I look up diabetes, I'm not going to my behavioral manual, right? I'm going to a medical journal or a medical book. So we've approached addiction like a behavioral disorder, and we treated it like a behavioral disorder. And for years we've did this. And what do we do with behavior as a society? We would treat behavior, we'd punish bad behavior to get a specific outcome. We used fear tactics like in the 80s. You can see on the right here, this you probably remember this ad on TV. This is your brain. They're showing an egg. This is drugs, the frying pan, and then they crack that egg open, they fry it and said, this is your brain on drugs frying. So they would use scare tactics, they would incarcerate drug users, and we realized, hey, how are our outcomes? And our outcomes were obviously horrible because, like I had mentioned before, 129 times higher likelihood that they're overdosing and dying. We had lots of recidivism. It really wasn't working well. So our approach wasn't working. Next slide. So we had to think about addiction. And as we've learned a little bit more how to study addiction, we've realized that it acts more like a chronic disease than anything else. And other chronic diseases like diabetes, hypertension, and asthma, we don't cure those disorders, right? We will manage those disorders so patients will have better outcomes in their lives. And sometimes we'll use medicine as well. But it isn't just give somebody a medicine and you're cured, right? For diabetes, I don't say, hey, guess what? I'm going to put you on insulin and now you can go eat all the donuts you want. That's not how it works. You have to combine it with behavioral change as well. I'm going to tell you, you're going to have to exercise, you're going to have to lose weight, you're going to have to watch what you eat, and you still might need some medicine as well. And if we approach both aspects, the behavioral aspect as well as the medical aspect, we have better outcomes. We might need to use medicines, but bottom line is you have to also have some behavioral change too. Next slide. So why do we start medications for opioid use disorder in jails? Well, that's where the patients are, like we had just talked about. We have a huge percentage of patients going through our system. And what we've done in the past is basically just treat their withdrawal symptoms. We had detox them. We had horrible results. We finally can do more. And we're going to talk about what we can do. We use medications. The reason we use medications, they're proven to work, right? These medications make the recovery process much safer. When you are in the throes of addiction, it's not just a behavioral issue. There are physical, real changes that are going on in the brain. We didn't quite understand that initially, but as in the last couple of decades, we've been able to study the brain a lot better and realize there are changes happening in the brain at the cellular level at times. We do know without, without medications for opioid use disorder, we see about 80 to 90% relapse back to drug use within that first year. When we use these medications, we see decreased death rate, we see increased treatment retention, we see 80% decrease drug use and crime. Remember that recidivism again. They're not going out and committing as many crimes because they're in treatment and not having to commit a crime to take care of their habit that costs a lot of money, by the way. And then overall, we see a 50 to 60% decrease in all-cause death rate. Here's a statement from the National Sheriff's Association. By facilitating continued access to medications for opioid use disorder for individuals who are on prescribed FDA-approved MOUD, correctional agencies can minimize the risk of post-release overdose and death. For individuals with opioid use disorder who are not receiving MOUD prior to arrest, correctional facilities can offer MOUD before release, taking into account individual preferences and clinician judgment. So that's a great statement saying, hey, we are behind taking care of this population. Not only did they go through the correction setting, yes, they're paying their dues for the crime that they committed, but at the same time, how do we help them be successful in life and not commit another crime in the future as well? And I think this is a great approach. There are 3 FDA-approved medications. You can see them listed here. One's called methadone. You've probably heard about that before in the past. It's been around like 8 decades now. Buprenorphine and naltrexone. Buprenorphine is often called Suboxone or Subutex. Methadone and buprenorphine are what we call agonist medications. They turn on a receptor, while naltrexone kind of blocks a receptor. And we'll talk about each one a little bit. Methadone is, I'll go back just for one second. I'm sorry. Methadone is a medication, and because it's a full agonist, which we're going to talk about in a second, is only able to be given in a clinic-based opioid clinic. So you've heard of an OTP, opioid treatment program. A patient has to go to that facility to get that medication because it's something called a full agonist. That means there is the risk for overdose if you take too much of that. Buprenorphine, on the other hand, is a partial agonist, which is safer, and we'll talk about that in a moment. And naltrexone is what we call an antagonist, which blocks that receptor. Next slide. So you can see depicted here on the right side, the methadone completely occupies that receptor. Buprenorphine partly occupies that receptor, and naltrexone, when it blocks that receptor. So the receptor just kind of works normally. It doesn't get affected. So if you have a drug of abuse that comes in and tries to attach to those receptors, it's being blocked by these three drugs here. So the drugs, these medications, the methadone, buprenorphine, naltrexone, they occupy that brain receptor and they hold on to it fairly tight. And so other drugs cannot get to those receptors. And when a patient has these medications at the right dose, and it's been individualized for that person, they have normal brain chemistry. They just feel normal. Like the most frequent thing I hear from patients after they're stabilized on their medications is like, oh my gosh, I feel normal. I haven't felt normal for years. It's almost foreign how they feel. It's kind of exciting to see that. They're not living with cravings. They're not going through withdrawals. They're not, I mean, they're having normal bodily function. We'll see women sometimes who haven't had a menstruation for years, suddenly they start having menstruation again because their body is starting to normalize. And we do individualize. We don't, it's not one size fits all. We individualize what medication they're going to use. We individualize the dose that is needed, and we monitor that quite well. Over a long period of time, we've noticed that there's no negative effect on intelligence, mental capability, physical functioning, employability when patients are stabilized on these medications. If anything, we just see improvement of human life. Next slide. Methadone, like I'd mentioned, has been around like 8 decades. It's most successful and it's used long term. It reduces, we know the studies prove this, that it reduces transmission of infectious diseases, right? They're not sticking needles in their arm. We actually see decreased sexually transmitted infections as well. We see reduced criminal behavior. We see an increase in treatment retention. So patients that are stabilized on this medication at the right dose, then they feel like, I feel normal. I can have a normal life. And so we see increased treatment retention, which is fantastic because they're usually doing quite well in that situation. It reduces the overdose mortality. So if there was a relapse, their receptors are already covered. And so they don't have overdoses in this situation because the receptors are covered. It's blocking the other drug that's coming in, especially when we're talking about fentanyl. We've seen a lot of people overdosing on fentanyl in our society. If we look within the methadone clinics as well, and people that have used fentanyl, they're still at the methadone clinic because they didn't overdose and die. So that's pretty protective, which is fantastic. So, there are some side effects to methadone, but they're quite manageable. We know what to look for. We know how to treat those as well. And so you can live a very long time. You can be on this medication a very long time if that's what you need. But we also have the ability to taper people off when they're ready to do that as well. Buprenorphine is what we call a partial agonist. That means it partially turns on that receptor. Remember, I'd mentioned before, methadone and almost all opioids are full agonist medications. That means if you take too much of a full agonist, you can stop breathing. You can overdose on that medication. Buprenorphine, being a partial agonist, only partly turns on that receptor. That means if somebody takes too much of buprenorphine, it actually does not go over the respiratory center. So they don't stop breathing and overdose. Because of that, it has what we call a ceiling effect. It's safer. It's safer. It has some limitations on how well it's going to block, but it blocks pretty darn well because it really likes to attach to that receptor and doesn't let go. And so it competes, what we call competes for that receptor. So if other drugs of abuse are trying to get there, they can't get on. Even though buprenorphine's partial agonist, they can't get on that receptor because buprenorphine really likes that receptor. It holds on to it much tighter than almost everything else as well. We do know that there's less abuse prone. It blocks more abuse prone opioids as well. So it's really uniquely suited to treat opioid addiction. It is less dangerous, right? So you have less chance of overdosing on that. It's less abuse prone than we see with methadone as well, because methadone is a full agonist as well. It's more likely to abolish craving. We do know that methadone actually works quite well with abolishing craving as long as you get them to the right dose as well. But it protects that user from an overdose by other dangerous opioids. Both of these medications, buprenorphine and methadone, when a patient is on it, if they were to have other opiates come into their system, it gets blocked, right? Because it can't attach to those receptors. Next slide. Naltrexone is that third FDA-approved medication we talked about. Sometimes you'll hear it called Vivitrol, which is a long-acting injectable. And I should have mentioned buprenorphine actually comes as an injectable as well. So that's kind of a newer kid on the block. A couple of medications called Brixadi and Sublocade are the brand names for those. But the long-acting injectables are actually have been quite successful with the buprenorphine. Naltrexone, or the long-acting injection called Vivitrol, we use that quite a bit in the jail settings. It's best for patients that have not really done well with either the methadone or buprenorphine. This medication has to be given to people that have already gone through detox. So they've already detoxed, they don't have any opiates in their system. You almost think about naltrexone like a long-acting Narcan, right? It's a long-acting naloxone medication, and it kind of gets on that receptor. It'll knock off other opiates, and then it'll just sit on that receptor. So if another opiate comes around and tries to get to that receptor, it's blocked. It also has a secondary use for alcohol use disorder. So it helps block the alcohol receptors as well. So if somebody's on naltrexone and alcohol is introduced into their system, the alcohol can't attach to those receptors as well. So there's a decreased chance that people are going to continue to drink when they're taking this medication too. It reduces opioid use and those related symptoms. It's effective at preventing relapse because if you take that drug or you take that alcohol and you have an expected result and you don't get it, then that is kind of negative feedback. I'm not going to do that again. That was a waste of money. And so it's really safe for most people. If people have severe liver disease, we usually withhold this medication, but it has been shown that it is safe in most people. And even in pregnancy, we won't start this medication for pregnant women, but if pregnant women are already on this medication, the American College of OB/GYN actually recommends just continuing this medication as well. Next slide. So Florida, the jail throughout Florida, we have 38 counties that have some of this medication. They don't have all three. Very, very few of the counties actually have all three of the medications, but 38 of the counties have at least one of these medications and is already offering medications for opioid use disorder for our patients. And you can see the list here. Hopefully we'll have all the counties soon. Some of the barriers we'll hear to access at times will, and there's a lot of stigma still behind this, right? And there's a lot of, I mean, obviously, this is a population that's being incarcerated for actions that they have done. So we get it. We're not trying to minimize the fact that what they did was wrong, but at the same time, like, how do we prevent them from doing it again? And how do we prevent them from dying when they leave? And so that's why we're talking about this program. And sometimes you'll hear like, well, all you're doing is just trading one addiction for another. Well, we are changing the drug, right? We are changing it to something that's much safer. It's long acting. They're not getting euphoric. They're not overdosing. If they were to relapse, they're protected from that as well. And what we see is people start to feel normal again and they get their lives together. And we see decreased death rate. We see decreased infection. We see them get jobs again and money in their pocket and start to succeed where they're starting to get their families put back together and their kids back. That's a really big deal. And so it really is not changing one addiction for another. You are giving this person's life back. Yep, they might be dependent on a medication, just like patients might be dependent on insulin. But the point is their life is improving with this medication as well. We'll see, and so sometimes you'll see that reluctance, obviously, to adopt some of these programs because there's stigma behind that, but also there's a fear of diversion, right? So if I'm going to give this medication out, it's just going to get diverted into jail. We already know jails have a problem with diversion and bringing in drugs from the outside as well. I'd mentioned before, I think some of the injectables could be the answer for some of that diversion concern. If people are taking the buprenorphine, which is typically a sublingual medication, if they were taking an injection from that standpoint, they can't divert that medication. So that would be something to consider. And also with the long-acting injectable naltrexone, that's also an injectable, so they can't divert that as well. Plus, there's no actually abuse potential with the naltrexone. Some of the policy and legal barriers are our policies that prohibit the use of MOUD in some areas. That really needs to be broken down. There's fear of legal consequences if something goes wrong with medication administration. I will tell you there's active lawsuits out there talking about the opposite. If you fail to treat a patient with a known opioid use disorder and they go out and overdose and die, then you're liable. And we've actually seen that in the ER setting where a patient came in with an overdose. We said, hey, just go get treatment. We didn't offer the life-saving medication that we actually had available. we're liable for that patient's death. We had something more that we could have offered that patient. And I suspect we will continue to see more lawsuits that will be in favor of getting this changed. So we'll start these medications for patients. It is the standard of care. It is the standard of care for opioid use disorder. I'll hear sometimes that there's, a lack of necessary training for custody and medical staff. You're right. That's why we're having this recording. That's why we're talking about it. We're trying to tell everybody we know about this because we do need to let everybody know that it's actually pretty straightforward. It's pretty simple to actually start. It's pretty safe, and it has huge benefits for not only the patient, but also the whole system. Because if that patient's not going to keep coming back through the system, that's a big win for everybody too. The resources to implement MOUD programs, yeah, everything has a cost to it as well. Those are things that we constantly talk about, and we're often just advocating trying to get more funding for that too. But if we can start making a dent in this major problem that's causing so many patients to come through the incarcerated system, then the correctional system, then we're actually going to help decrease the cost of that as well overall. Next slide. Some of the benefits we talked about, we see reduced recidivism, right? These patients that are stable on their MOUD are less likely to be reincarcerated. They reduce rebooking rates. It increases the time between the bookings as well. There's fewer days spent in jail, which is obviously what we just talked about, significant cost savings in regards to that. There's also healthcare savings. Patients that have opioid use disorder that are putting needles in their arm, there's a huge risk of infection, endocarditis, valve replacement. It's unbelievable the amount of money that is spent from the secondary consequences of drug use. And so if we could actually stop that as well, we'd have huge healthcare savings from that standpoint. And we have that opportunity, right, to make that change with that inmate and really start them on MOUD where their risk of overdose or risk of continued healthcare issues are going to go down dramatically. And we see an decrease of overdose too. Go ahead. We see improved outcomes, like we'd mentioned, in inmate health and behavior, reductions in overall death, reduction in criminal activity, overall cost for the savings for the facility's health services. And there's an economic benefit, obviously, increased employment for those who receive treatment. We know actually, just within our own studies within methadone treatment, we know if we get patients stabilized on methadone treatment, their employment goes up dramatically. Like they might have 10 or 20% of the people that are employed, and by the time at 1 year, about 70 to 80% of our employed. So we see that they're actually being good citizens. They're actually working hard and getting a job, which is fantastic, and that helps them integrate back into society much better in regards to that too. All right, next slide. Here's some data we had talked kind of briefly discussed this as well. In Massachusetts, they had a 29% reduction in recidivism among inmates receiving buprenorphine during imprisonment. Remember, that's Suboxone is the other name for that as well. They had an increased reduction of 32% after adjusting for factors like prior incarcerations and sentencing status. So really great benefit there, obviously, decreasing the fact that they're not going to come back as often. When they used that extended release buprenorphine, like I talked about before, compared to just the daily sublingual buprenorphine, they had even more dramatic results as well. Look at this, 69% treatment retention post-release for extended release buprenorphine. That means they continued on their treatment as an outpatient compared to about 35% when they were using oral buprenorphine. Now remember, 35% is really a good number, right? Compared to 0. Now we have up to 70% of the patients that are getting the injectable are actually following up outpatient. What does that mean? That means they're not going out and committing crimes to get their drugs. So they're going to have a decrease, even a higher decrease risk of recidivism in that situation. There's a Maine jail study. This is a real world of evidence from a jail in Maine. It indicated that individuals treated with extended release buprenorphine, like we talked about there, were more likely to remain in treatment post-release, with approximately 67% continuing treatment without interruption compared to 23% on the daily sublingual buprenorphine. Very similar to the study that we had just talked about. New Mexico had a different stance on this. They looked at, not a different stance, they looked at methadone when they introduced methadone maintenance, they had 29.3 fewer incarceration days for those patients that were actually started on methadone. That treatment, remember, methadone is actually probably the cheapest of all three of the treatments. It only cost about $23 a day to prevent future incarceration days. And as we know, on this study, the average day of cost of incarceration is $116. So that's a dramatic savings, $90 savings per day just because we had actually treated somebody, got them stabilized on methadone. Next slide. Is this still me? Okay. So how do we implement this? Successful implementation, obviously, we have to have funding. We had talked about that before, and we'll continue to advocate to have that funding. We need trained staff that understand this with decreased stigma, right? We understand like, hey, this is the standard of care. These are the medications we can use. It's actually pretty straightforward. As a matter of fact, if I get a patient that's stabilized on these medications early on, then they're not going through withdrawals. They're not getting sick. I'm not having to send that person to the emergency department because they're miserable. I'm going to have decreased contact from medical because they're actually feeling okay. And when they leave incarceration, their chance of overdose goes down dramatically. And guess what? I probably won't see that person as often as I would have seen them because they're not coming back and being incarcerated again. So that collaborative approach between the correctional facilities and healthcare providers, community-based organizations is a huge piece of this as well. Where do people go after they leave incarceration? And that's why those relationships are very important, to establish those relationships with your community partners. Like, where is my patient going to go? I started them on medications. Will you see them as an outpatient? And we actually have those facilities available and people willing to do that. So we just need to continue to make sure that we bridge that relationship as well. Jail-based MOUD programs can serve as that bridge to ongoing treatment upon release, reducing that risk of relapse and overdose. Next slide. All right, so lastly, correctional facilities, they provide that critical opportunity to save lives. We can start those medications, the life-saving medications that treat opioid use disorder. There's a high risk of overdose, like we'd mentioned before, especially for those ones that are released into society without getting medications. These medications are the gold standard. This is the standard of care for opioid use disorder. They reduce the overdose risk and obviously have a lot of other benefits as well, especially when we're talking about not being reincarcerated as again, starting that medication immediately upon incarceration and helping those individuals kind of deal with not having to go through severe detox or getting sick, but also preparing them for success when they leave incarceration, going back into outpatient treatment in the community, they're going to be more successful. And methadone and buprenorphine reduce the overall overdose risk by 50% compared to treatment without medication. So there's a huge savings there. Now, jails might not be the ideal setting for opioid use disorder, nor is the ER sometimes, but they offer that crucial chance to intervene and save lives. So maybe we really are the ideal setting to start that as well. That's where the patients are, and that's where we can actually make the biggest difference. Diana?
Thank you, Dr. Thank you, Dr. Stavros. Before we go any further with the presentation, I'd like to go ahead and ask you a few questions that I know are commonly asked during our presentation. What MOUD options are most commonly used in jails and why?
So what I've seen, at least within the Florida jail setting, we've seen a lot of naltrexone used, which is the opioid blocker, which has some benefits, right? But the downside, I would say this, because people get excited about the naltrexone. They're like, oh, it's not an opiate. It can't be diverted. It must be a great drug. Well, not so fast. It has its place. One, the patient has to be detoxed first. And as we know, that is kind of wrought with some difficulty as well. If that patient's been detoxed, we can start that medication too. Now, they have to stay on that medication. If they go off of that medication, they don't have withdrawals, but they will start having those cravings come back again. And so that's a risk of overdose at that point. So we want to make sure that patients will continue on that medication. So we have to make sure it's the right patient, the right fit, and the patient has to be willing to try that as well. We've had good success with those specific patients that have been detoxed and want to be, when they get released back out into society, that they'll be on this medication prior to them leaving. We start this medication in the jail before they leave, because if we wait for them and they leave, remember what I said, 129 times higher likelihood of overdose in the first 2 weeks. So we've got to start treatment before they leave. So I would love to see buprenorphine and methadone introduced within the jails as well. I know there's always a concern about diversion. Methadone's pretty quick. You have to swallow it. It's gone. It's in your belly. And so that's fast. Buprenorphine, it takes a while to melt under the tongue. That's why some people, you'll hear things called cheeking it. There's concern about people maybe diverting that. But when we introduce the injection, it can't be diverted. It's like it's in there and it's stuck in there. And they get one shot a month. And so I think that's a huge option there for jail settings, especially.
Right, here's another question. Are there any state or federal mandates requiring jails to provide MOUD?
Yeah, I don't think I'm not familiar with any state or federal mandates that require it, but I will tell you this. When you talk about the standard of care, could you imagine somebody saying, well, the state and federal guidelines don't mandate that I give this patient insulin? Because I don't know if there's a rule for that either, but it's like, how could you not treat them with the standard of care? This is a life-saving medication. So just like just like diabetes has its life-saving medication, opioid use disorder has its life-saving medication as well. And so it has become the standard of care. It is the gold standard. And if jails say, well, we're just not going to do it, it's like you are actually giving substandard care at that point, and I think you're at risk.
All right. How are inductions and continuity of care managed for individuals entering or leaving jail?
So it depends. I mean, we want to have patient understanding of what the medications are, and depending what medication they want to be started on, we can start the medications within the jail setting. We can work with the medical team. We can have outside people come in and actually give medications. We'll have methadone clinics that will bring the medications to the jail. Jails can actually become methadone clinics, believe it or not. They can actually store that there. There's just a process for doing that. And it's a little bit more of a heavy lift, but we can partner with methadone clinics so patients can actually start the induction in the jail. They're being seen by medical, and when they get to a stable dose, they're actually doing better. So, and they're very stable. They're not sick. They're not withdrawing, and they just feel normal. They can be functional again. Buprenorphine, same type of thing. We could bring the medication in there, but typically, because it's a partial agonist, it can be at the jail. They can administer that medication, especially when we're talking about injectables. That would be a wonderful way to do it, because you don't have to give the medication except once a month. So that's a lot easier. Naltrexone, like I'd mentioned before, that can be a medication that just stabilizes that brain after they've gone through detox, but it's especially important to start that near the end when they're about to be released back into society. It'll be protective for them.
What are the biggest challenges that jail faces when they want to implement MOUD?
Say that one more time. I apologize.
What are the biggest challenges that a jail faces when implementing MOUD?
Yeah, I think the biggest challenge is probably the stigma, to be honest with you. I think there's a lot of people that kind of have the mindset of this is supposed to be a punitive kind of environment. They should be punished for this, and that's fine. They actually are paying their time in the jail setting, but at the same time, we need to think about the future. We need to think about the next situation as well. So helping patients get on these medications is not only going to keep them alive, but it's also going to help them thrive in life and hopefully not come back to the jail as well. So I think that's a huge barrier, just changing the stigma. Once you get a few people that are champions, that really changes everything, because then you start realizing, like, wow, this is a lot easier than I thought. Because I think it's a lot bigger in our head. Like, how do we do this? I'm pretty worried about how it's going to look, you know. And really, once you start it, you're like, oh my gosh, this is a lot simpler than I thought. And then you can start reaching a lot more patients as well, because that stigma goes down, the word gets out that you're actually helping people. And then hopefully we can have that kind of expand and get to the people that need the help. So.
One final question. How can partnerships with community providers support continuity of care?
Yeah, like we'd mentioned before, having those partnerships is really key, right? Because you want to make sure that if that person is leaving incarceration, where are they going to go? You want to make sure that they're going to continue their medication, because we know if they continue their medication, the chance of them dying goes down. The chance of them committing another crime goes down. The chance of them getting a life-threatening infection goes down. What happens is they start to improve their life. So we want them to continue with these medications as an outpatient. So having those relationships is imperative.
Well, thank you, Dr. Stavros. So I'm here today as with FATA to let you all know that we do have a training available to your organization at no cost to train your jail staff on corrections and opioid use disorder training. Our training objectives are how get them to understand that opioid use disorder is a brain disease, and also learn about the medications and how the medications support the road to recovery. Learn how the FDA approved medications are used to treat substance use disorder, and how they can also help change behaviors while they're in the incarcerated facility. Our training is targeted for your custody staff, reentry and treatment staff, your mental health staff, and your medical staff. We come in with a trainer that is an expert in this area that has worked for many years in the field of substance use treatment. We also that have worked in jails, and we want to share this opportunity with you. Our training it lasts for 3 hours. Of course, there are breaks. We will provide a PowerPoint. Also, during this presentation, we'll have a medication expert on the call, like Dr. Stavros is today, to take a 20 to 30-minute session with your staff to answer any questions they have related to the medications. The only responsibilities that we ask that your organization provide is the training room, of course, attendance by your employees, and also the availability of being able to share the PowerPoint in rooms at a classroom setting, that we're able to come in and be able to answer those questions. We also make sure that we have internet access, and we'll also provide a handout and booklet to your staff. Again, this training is provided at no cost to your facility. We have already been into 17 counties across the state of Florida. We have trained close to 1,000 staff members within several of those organizations. On the screen, you'll see several comments. We've been to Collier County, we've been to Okaloosa County, Orange County, and Seminole County. They all have great active programs, and I'm sure if any of you feel the need, they would be more than happy to share their experience of the training with you. Again, these are comments that they've approved me to share with you all today. Also, we have some great resources here if you'd like to learn a little bit more about the medications, about access to other types of trainings or funding sources. Please check out the Department of Children and Family. They are happy to share their information with you. And there's some other resources that we have available for you today. And again, I want to thank you all for listening to this presentation. If you do have any questions or comments or would like to hear further information about the training, feel free to reach out to me. My information is on the screen. The best way to reach me is by email, and I will respond quickly. We will have a short phone call, discuss your needs, and be able to help provide you with the education that you're seeking for your staff. Again, we want to thank you for taking the time today to listen to this presentation, and hope that we hear from many of you as we move forward. Thank you so much, and have a great day.
Thank you. Bye-bye.